Whether you are a medical student furiously prepping for your upcoming board exams, a junior doctor on the wards revising your medico-legal principles, or even a senior clinician revisiting the critical forensic foundations of your practice, you know that some topics just demand far more of us than others.
They really do.
Today, we are taking a deep dive into the most delicate and heavily scrutinized area of forensic medicine, which is deaths and injury in infancy.
It is an area that requires not just encyclopedic medical knowledge, but profound professional restraint. I mean, in these infant cases, forensic medicine absolutely must combine uncompromising scientific rigor with incredibly measured language.
Right, because the objective here is always truth.
Always truth is never suspicion. We are navigating the highly complex interplay between natural vulnerability, accidental harm, and tragically inflicted injury. The stakes could not be higher because our findings have the power to protect a vulnerable child or completely destroy an innocent family.
Before we begin, a clear disclaimer. This deep dive is a conceptual exploration designed to support you as you read the text. It will help build your conceptual frameworks, but it is not a regurgitation of the text and is absolutely not a replacement for reading the chapter. We strongly encourage you to read Chapter 7 of Simpson's Forensic Medicine alongside this deep dive.
And our mission today is to build a clear, structured framework for you. We will be following the exact sequence of Chapter 7 of Simpson's, mapping out the journey from the underlying mechanism of an injury or condition to the resulting physical pathology, then the clinical interpretation, and finally, the medico-legal implication.
We want to give you clinical and biomechanical anchors for your memory so that when you are in an emergency department or sitting an exam, the reasoning flows logically rather than you just relying on rote memorization.
Exactly.
So we often hear in pediatrics that children are not just small adults. It's a bit of a cliche, but from a forensic and medico-legal perspective, the implications of that biological reality are massive, aren't they?
Oh, entirely.
Yeah.
An infant's physiological and structural baseline changes the entire forensic landscape. The outcomes of disease and trauma might theoretically seem like they should just scale down linearly, but the reality is completely different.
Because infants and younger children possess vastly different body proportions.
Right, they have structural differences, like incomplete skull-bone fusion and highly pliable rib cages. Their metabolic responses are distinct, they possess remnants of fetal circulation, and their thermoregulatory mechanisms are highly immature.
And beyond the pure biology, there is the undeniable social reality. They are completely, fundamentally dependent on others for survival.
Which is the core of it all. This inherent vulnerability introduces a spectrum of risks, be it emotional, physical, and sexual, that are completely distinct from the risks faced by autonomous adults.
That biological and social distinction brings us directly to the first major conceptual hurdle in forensic pathology regarding the very young, and that is the medico-legal definition of when life technically begins, and conversely, what happens when it doesn't.
It's a heavy place to start.
It is. The law has drawn a very specific, firm line in the sand regarding stillbirths, and it's a line that often creates a lot of friction with modern clinical realities.
The legal framework is quite rigid, yeah, and as you mentioned, it has shifted over time to try and catch up with medical science.
Yeah.
We look at England and Wales as our primary example. The governing framework originates with the Births and Deaths Registration Act 1953.
But the crucial update for your conceptual framework, the anchor you really need for exams, is the Stillbirth Definition Act 1992.
Right. The 1992 Act changed the threshold of viability. It defined a stillbirth as any baby born after 24 or more weeks of completed gestation that did not at any time breathe or show signs of life.
And prior to 1992, that threshold sat at the 28th week of gestation.
It did. The shift from 28 to 24 weeks was a direct acknowledgement of the advancements in neonatal intensive care. Medicine was keeping 25 and 26-week-old premature infants alive, so the legal definition of a stillbirth simply had to move earlier to reflect that new threshold of potential viability.
So under the current legislation, there are no provisions to allow the registration of a stillbirth before the 24th week of pregnancy.
None. If a fetus is expelled at 23 weeks and 6 days and shows no signs of life, it is legally classified as a miscarriage, not a stillbirth.
But with modern NICUs, we regularly see 23-weekers and occasionally even 22-weekers survive. Doesn't that rigid 24-week legal line create immense friction for obstetricians and grieving parents today?
It creates profound friction. The law requires a binary threshold for administrative and legal purposes, but human biology and medical intervention operate on a fluid continuum. The 24-week mark broadly represents the point of fetal viability in the eyes of the law, but the clinical reality is often much grayer.
However, for your exams and for strict medico-legal documentation, 24 weeks completed gestation is your absolute anchor point for a stillbirth registration.
Keep that locked in your memory.
The text provides some really interesting historical context on the sheer volume of these cases, and the numbers are staggering. Stillbirth registrations began on July 1st, 1927 in England and Wales. Back then, the estimated annual number of stillbirths was over 26,000.
Which is it's hard to fathom. But fast forward to 2017, and that number plummeted to 3,284.
Wow.
That drop over the 20th century is one of the most significant yet rarely celebrated public health achievement in modern medicine.
It maps perfectly onto the advancement of maternal and fetal medicine, the implementation of widespread prenatal care, better management of maternal infections, the pharmacological control of maternal disorders like hypertension and gestational diabetes,
And vastly improved management of intrauterine hypoxia and birth trauma.
Yet, even with all those clinical advancements, a frustrating reality remains for the forensic pathologist. The specific causes of many stillbirths remain totally unknown.
They do. Even after a comprehensive, specialized pediatric postmortem, which includes extensive histology and placental examination, it can sometimes be impossible to determine on pathological features alone if the cascade leading to death initiated days before birth or hours before.
Which brings us to a really critical distinction for the pathologist. Interpreting the postmortem changes. If a fetus dies in utero, the physiological environment dictates the breakdown of the tissues. We need to clearly differentiate between maceration and putrefaction because they are driven by entirely different mechanisms.
You have to consider the microenvironment. Putrefaction, which we observe in deceased adults or in babies who are born alive, breathe environmental air and then die, is driven by bacteria.
Right.
The endogenous bacteria from the gut combined with environmental bacteria introduced through the respiratory tract break down tissues in the presence of oxygen.
But a fetus in utero isn't exposed to air, and ideally, the amniotic sac is sterile.
Therefore, if death occurs in utero, say, several days before the actual onset of labor, the fetus undergoes maceration. Maceration is the effect of early decomposition combined with continuous, prolonged exposure to warm amniotic fluid.
So it's essentially a different process altogether.
It is a sterile, aseptic, autolytic process. The body's own enzymes are breaking down the tissues without the aid of gas-producing bacteria.
What does that actually look like on the autopsy table? How does the pathologist visually and structurally identify maceration versus putrefaction?
The visual indicators are highly distinct. A macerated infant is usually discolored, taking on a pinkish-brown or deep red hue, unlike the greenish discoloration typical of early bacterial putrefaction.
Okay.
You'll also observe extensive desquamation. This is skin slippage where the epidermis separates from the dermis and peels away in large sheets, often leaving a raw, moist surface beneath.
And the fluid environment causes the tissues to become highly edematous and soft, I imagine.
Yes, the tissues take on a very soft, almost slimy translucence. Structurally, because the internal tissues, including the brain, are undergoing autolytic liquefaction in a fluid environment, you see a loss of structural integrity in the cranium.
The skull just gives way.
It does. This leads to a partial collapse of the head with overriding of the skull plates, a phenomenon sometimes visible on prenatal ultrasound or postmortem X-ray, historically known as Spaulding sign.
The overriding of the skull plates is a vivid biomechanical indicator. The brain tissue loses its turgor, so the bones literally cave in on themselves.
And this appearance is vastly different from a live-born infant who undergoes standard bacterial putrefaction, which is characterized by bloating from gas production, marbling of the veins, and greenish discoloration of the abdomen.
But there's a clinical caveat here with timing, isn't there?
The critical caveat is time. Maceration requires the death to have occurred at least a couple of days prior to delivery. If the fetal death occurs right around the onset of labor, or during the birthing process itself due to an acute hypoxic event, you will not see any evidence of maceration. The fetus will appear perfectly intact.
So we have established the biological reality of stillbirth, but the legal reality is quite distinct, and it dictates the paperwork.
Legally, babies that are stillborn have never lived in the eyes of the law. They never achieved a separate, independent existence from the mother. And because they have never legally lived, they cannot legally die.
That's a stark way to phrase it.
It is, but therefore a standard death certificate cannot be issued for a stillbirth.
You cannot issue a death certificate for an entity that never achieved legal life. The logic holds, but it requires a different administrative pathway.
In England and Wales, a specific stillbirth certificate is completed. This documentation can be provided by a doctor or a registered midwife, provided they were present at the birth or they have physically examined the body of the child after birth.
There's also the Infant Life Preservation Act, 1929, mentioned in the text. This piece of legislation covers the incredibly tragic extreme scenarios that can unfold in the delivery room during obstructed labor.
The 1929 Act essentially made it a criminal offense to destroy a baby during the birthing process, to kill a child that is capable of being born alive before it has achieved a separate existence.
But there is an exception.
It carved out a crucial necessary exception. If a doctor is acting in good faith for the sole purpose of preserving the life of the mother, and they are forced to perform a destructive procedure on a baby that has become hopelessly impacted in the pelvis during birth, they are legally protected.
It highlights the harrowing, split-second triage decisions that historically, and very rarely currently, have to be made in catastrophic obstetric emergencies.
It really does.
Moving from the medical and legal realities of stillbirth, we enter an area fraught with even more profound legal complexity, which is the concept of infanticide. Okay, let's unpack this, because the law actually recognizes a very specific psychiatric and physiological state here, diverging significantly from standard homicide statutes.
When the general public uses the word infanticide, they usually just mean the killing of an infant. But in forensic medicine and the criminal justice system, specifically under the Infanticide Act 1938 in England and Wales, it has a highly specific statutory meaning designed to circumvent the rigid machinery of a standard murder charge.
Section 1 of the 1938 Act sets out a very specific set of parameters. It applies when a woman, by any willful act or omission, causes the death of her child. But the conditions surrounding that act are what change the charge entirely.
The first parameter is age. The victim must be the woman's own child, and the child must be under the age of 12 months.
Under 12 months. Okay.
The second parameter is the absolute crux of the defense. It must be shown that at the time of the act or omission, the balance of the mother's mind was disturbed.
And the law actually dictates the permitted physiological causes of that mental disturbance.
It explicitly links the psychiatric state to the physiological trauma of reproduction. The disturbance of mind must be by reason of her not having fully recovered from the effect of giving birth to the child, or by reason of the effect of lactation consequent upon the birth.
So it's a formal legal acknowledgement of things like puerperal psychosis.
Exactly. It is a rare example of the law formally acknowledging puerperal psychosis and profound postpartum depression as deeply mitigating physiological realities.
So if a mother causes the death of her 3-month-old infant and psychiatric evaluation confirms her mind was unbalanced due to these specific postpartum physiological effects, the legal categorization of the crime shifts completely.
Under this act, she is found guilty of the specific offense of infanticide, but crucially, she is dealt with and punished as if she had been guilty of manslaughter, not murder.
This removes the mandatory life sentence that accompanies a murder conviction in the UK.
That is the functional purpose of the act. Manslaughter affords the presiding judge judicial discretion. The court can craft a sentence that is actually appropriate to the complex tragedy of the situation. Instead of long-term punitive custody, a conviction of infanticide is much more likely to result in probation, community orders, and mandated psychiatric supervision and treatment.
But to even consider a charge of infanticide or murder or manslaughter, the forensic pathologist has to clear a massive foundational hurdle. They must prove, beyond a reasonable doubt, that the baby was actually born alive.
This is where the burden of proof becomes the pathologist's heaviest load. In England and Wales, the legal system operates on a strict presumption. All deceased babies are presumed stillborn until proven otherwise.
The law assumes the child did not survive the trauma of birth.
Yes. Therefore, the entire burden of proof falls squarely on the prosecution and the forensic expert to prove that the child achieved a separate existence from the mother.
How exactly is separate existence defined? I mean, demonstrating life on an autopsy table, especially if the birth was concealed and there were no eyewitnesses, sounds near impossible.
You must demonstrate undeniable physiological signs of life. Spontaneous movement, independent breathing, or sustained pulsation of the umbilical cord. But the legal trap is that these signs must be shown to have occurred after the infant was completely expelled from the mother's body.
Completely expelled, meaning if the baby's head delivers, the baby gasps and takes a breath of air, but the shoulders are dystocic and the body remains inside the birth canal, that doesn't count as a severed existence.
That is the exact, strict legal nuance. In a standard vertex delivery, an infant can absolutely initiate respiration after the head and thorax are delivered, while the abdomen and legs are still within the maternal passages. If the infant dies at that exact moment, they breathed air, but they never achieved a separate legal existence.
Wow.
Therefore, simply proving that the lungs contain air is not, on its own, incontrovertible evidence of a separate existence under the law.
That stringent legal definition makes the pathologist's job incredibly difficult, and it brings us to one of the most historically debated procedures in forensic pathology, which is the lung flotation test, also known as the hydrostatic test.
The lung flotation test has been utilized and argued over for centuries. The physiological premise is entirely sound. A fetus in utero has solid, dense, airless lungs. The alveoli are collapsed and filled with amniotic fluid.
So they're heavy.
Because they are dense, fetal lungs will sink in water. If an infant is born alive and takes sustained breaths, the alveoli expand with residual air, the lung tissue becomes spongy, its specific gravity drops, and the lungs will float.
But relying on that for murder conviction became highly controversial. The defense bar routinely tore it apart in court.
The skepticism was warranted. Pathologists raised concerns about false positives. If a stillborn infant begins to putrefy, the gas-producing bacteria create microbubbles of decomposition gas within the lung parenchyma.
Oh, I see.
This decomposition gas can cause a truly stillborn, airless lung to float in water, falsely suggesting the infant had breathed.
Yet the text highlights a recent study that reevaluated this ancient test, and the data is vital for a modern framework.
The recent data forces a recalibration. The study suggested the lung flotation test, when performed carefully by experienced pediatric pathologists who account for decomposition, is actually reliable in 98% of cases.
98% sounds excellent in a clinical diagnostic setting, but in a courtroom where the standard is beyond a reasonable doubt, isn't a 2% error rate still a massive legal liability?
It is, which is why we have to look closely at where those errors occurred in the study. Crucially, there were 0 false positive results, meaning the lungs of truly stillborn infants in the absence of advanced putrefaction never floated.
So if the lung floated, the study showed the infant was definitely not a stillbirth.
Right. However, the errors were false negative results. There were cases where a child was definitively known to have been born alive, but upon autopsy, their lungs sank.
So if the lungs float, you have strong evidence the baby breathed. If they sink, you cannot say for certain that the baby never took a breath. A shallow, transient breath might not retain enough residual volume to make the tissue buoyant.
Precisely. Lungs that sink cannot be presented as absolute proof of stillbirth. But the single most important clinical anchor regarding the lung flotation test is the intervention of cardiopulmonary resuscitation.
CPR.
If a parent, a paramedic, or a doctor attempted CPR on that infant, if they provided artificial ventilation via bag valve mask or mouth-to-mouth, the lung flotation test is immediately rendered entirely useless.
Because the rescuer forces air into the alveoli, mechanically expanding them, mimicking spontaneous physiological breathing.
Exactly. You cannot offer any reliable forensic opinion on spontaneous, independent breathing if resuscitative ventilation was attempted. The CPR negates the evidentiary value of the lung tissue's buoyancy.
If the lung test is compromised by CPR, or if you're dealing with the reality of false negatives, what other physiological markers can a pathologist look for to definitively prove a separate existence?
You examine the gastrointestinal tract and the umbilical cord remnant. If the forensic examination reveals confirmed milk or formula in the infant's stomach or small intestine, that is undeniable proof of life.
Because the infant had to be alive to swallow it?
The infant must have been alive with intact cranial nerve function to coordinate the suckling, swallowing, and peristalsis required to move milk into the gut. You also meticulously examine the umbilical cord. If the cord remnant is shriveled, dried out, or if histology shows a distinct inflammatory ring of leukocytes at the base, indicating the early stages of natural separation.
That takes time to form.
It does. The child must have lived for at least several hours after delivery for those physiological inflammatory processes to occur.
Those markers require relatively intact tissue. What if the child is found concealed, perhaps hidden in an attic or a shallow grave for weeks, and decomposition is advanced?
Then the medical evidence often hits a wall. Advanced putrefaction can completely obliterate the architecture of the lungs, destroying any reliable assessment of alveolar expansion, and it rapidly breaks down stomach contents.
So what happens to the investigation then?
In cases of concealed births with advanced decomposition, the medical autopsy often takes a back seat to standard police detective work. Law enforcement relies on CCTV footage, witness statements, digital forensics from the mother's phone, and ultimately DNA profiling to establish the identity of the infant and trace the parentage.
If the mother is traced and the pathologist can definitively prove the baby achieved a separate existence and was born alive, the prosecution then faces the next hurdle, which is proving the cause of death. The text draws a very clear legal and pathological distinction between acts of omission and acts of commission.
This differentiation is the core of many infanticide investigations. Acts of omission involve a failure to provide the normal, necessary care required to sustain a newborn's life immediately following birth.
Like failing to tie off the cord?
Yes, failing to tie and cut the umbilical cord, leading to exsanguination. Failing to clear the infant's airway of mucus or amniotic fluid. Failing to wrap the baby to prevent lethal hypothermia, or failing to provide nourishment.
But proving an omission was a willful, deliberate act in a court of law seems incredibly difficult. How do you separate malice from the sheer terror, ignorance, or shock of a young mother experiencing a painful, unassisted, concealed delivery?
You have hit on the exact reason why prosecutions for acts of omission are exceptionally rare and incredibly difficult to secure. Demonstrating a willful, deliberate withholding of life-saving care versus a state of paralyzing shock or physical exhaustion during a hemorrhage-complicated solo delivery is a massive challenge for prosecutors. The threshold for criminal negligence is incredibly high.
Whereas acts of commission are a different story.
Acts of commission, conversely, are medically objective and straightforward for the pathologist to demonstrate.
Because acts of commission leave a distinct physical signature of trauma.
Yes, inflicted trauma. Blunt force head injuries from being struck or dropped, stab wounds, drowning in a toilet bowl, or ligature strangulation. These acts leave clear, undeniable pathological signatures, fractures, hemorrhages, specific fluid in the airways that a forensic expert can rigorously document, photograph, and present to a jury as objective evidence of inflicted harm.
In investigations involving concealed births or unidentified remains, law enforcement often asks the pathologist to determine the gestational age of the infant. Estimating maturity is a crucial piece of the investigative puzzle.
Interestingly, maturity is rarely a legal defense issue in an infanticide trial. The Infanticide Act applies to any child under 12 months, provided they had a separate existence, regardless of whether they were born prematurely at 32 weeks or full term at 40 weeks.
But for the police investigation, it's vital.
For trying to match a deceased infant to a missing person report or a suspect's timeline of pregnancy, estimating gestational age is paramount.
The text mentions a classic historical method, Haas's formula. It's a 19th century mathematical rule of thumb based on fetal length.
Carl Friedrich Haas, a German obstetrician, devised it. It states that for the first half of pregnancy, the fetal length in centimeters roughly correlates to the square of the age in months. In the second half of pregnancy, you multiply the age in months by 5 to get the length in centimeters.
It's surprisingly rudimentary math. Given that human biology has massive variations based on placental health, maternal nutrition, and genetics, I imagine modern pathology has moved far beyond relying on a simple multiplication table.
It has. Haas's formula is a historical footnote, an incredibly rough rule of thumb that hasn't been rigorously validated by modern, diverse population studies. For living infants, neonatologists utilize the new Ballard score, which assesses complex neuromuscular maturity and physical criteria like skin texture and plantar creases.
But a forensic pathologist examining a deceased infant cannot assess neuromuscular tone or reflex responses.
Exactly. So postmortem maturity estimation requires a deeply integrated, multi-professional approach. You don't just measure a baby with a tape measure.
What's the modern toolkit look like?
You employ anthropological techniques, such as precisely measuring the diaphyseal length of the femur or humerus. You utilize histology, microscopically examining the development of renal glomeruli or the maturation of the alveolar spaces in the lungs, and you rely heavily on radiology to identify the presence and size of specific ossification centers in the skeleton, like the distal femoral epiphysis.
Box 7.1 in the text provides a clinical reference guide for this, right?
It does. For instance, at 24 weeks, our critical legal threshold for stillbirth viability, you expect to see a crown heel length of roughly 30 centimeters, very thin red skin, and the widespread presence of vernix caseosa. By full term, at 40 weeks, you're assessing an infant around 48 to 52 centimeters long, with head hair that may be several centimeters long, testes fully descended into the scrotum for males, and the presence of dark, sticky meconium in the large intestine.
That multidisciplinary approach, integrating radiology, anthropology, and histology, is really the defining feature of pediatric forensic pathology. But age estimation is just one piece of the puzzle when an infant is found deceased. The hardest cases are the ones where age and identity are known, but the mechanism of death is a total void.
Those are incredibly challenging.
This brings us to the complexities of unexplained deaths in infancy, where we must untangle SUDI and SIDs. I want to make sure we define the terminology perfectly because the media frequently uses them interchangeably, but medically and legally they are completely distinct.
Precision in terminology here is absolutely paramount. SUDI stands for Sudden Unexpected Death in Infancy. This is a broad, descriptive umbrella term. In the ICD-10 coding system, unexplained infant deaths that occur suddenly and initially have no obvious medical cause are coded as R99.
So it's just an initial placeholder.
It simply describes the presentation. An infant died unexpectedly, and at the outset of the investigation, we do not know the mechanism.
And how does SID, sudden infant death syndrome, fit into that diagnostic framework?
SIDS, coded distinctly as R95, has a highly restrictive exclusionary definition. SIDs is defined as the sudden death of an infant less than 1 year of age that remains entirely unexplained after a complete, specialized autopsy, an exhaustive review of the clinical history, and a thorough death scene investigation.
SIDs is the ultimate diagnosis of exclusion. You have systematically ruled out occult infection, accidental asphyxiation, undisclosed trauma, congenital heart defects, and rare metabolic disorders. If the multidisciplinary review is left with absolutely nothing, the label applied is SIDs.
Exactly. It is not a specific disease entity that you can test positive for. It is the conceptual bucket we use when every known pathological avenue has been exhausted. Despite immense research, it remains the most common cause of death in the postperinatal period in the developed world.
What does the epidemiology reveal? Who falls into this tragic demographic?
The patterns are highly specific. The vast majority of SIDs deaths occur between 1 month and 6 months of age, with a very sharp pronounced peak occurring at 2 months of age.
What is happening physiologically at 2 months that creates this window of vulnerability?
It is widely believed to represent a critical transitional window of neurodevelopment. At around 2 to 3 months, the infant's brainstem, specifically the neural networks controlling arousal, cardiorespiratory control, and autoresuscitation in response to hypoxia, is maturing and reorganizing.
So it's a vulnerable phase.
Yes, during this transitional phase, the infant might be particularly vulnerable to exogenous stressors. This aligns with the triple risk model of SIDS. A vulnerable infant, in a critical developmental period, exposed to an external stressor. Beyond age, there is a slight statistical preponderance in male infants.
And multiples are at higher risk too, correct?
The incidence is markedly higher in multiple births, though that is partially confounded by the fact that multiples are frequently born premature and with lower birth weights, which are strong independent risk factors for SIDS.
What about environmental and socioeconomic factors?
There is a striking seasonal variation. In temperate geographic zones, SIDs incidence reliably spikes during the colder, wetter winter months. And while SIDs can strike any family in any demographic, there is a very strong, undeniable epidemiological link to socioeconomic disadvantage.
How so?
There is a higher incidence observed in families facing poverty, overcrowded or poor housing conditions, lower occupational status, and in young single-parent households.
The text points to the Back to Sleep campaign initiated in the early 1990s. That remains one of the most effective public health interventions in pediatric history.
It was a monumental shift in pediatric guidance. Before the early 1990s, the prevailing medical advice often encouraged parents to place babies to sleep prone on their stomachs, under the misguided belief it prevented aspiration of vomit.
Which we now know is terrible advice.
Yeah. The Back to Sleep campaign aggressively reversed that, urging parents to place babies solely supine on their backs. That single, simple intervention, combined with strong public health advice against maternal smoking during pregnancy and warning parents to avoid overheating the infant with excessive blankets or clothing, led to a precipitous drop in SID rates worldwide.
And just for context on the rarity today, in England and Wales in 2016, there were 219 unexplained infant deaths. It is rare, but the impact is devastating.
Devastating.
So a healthy baby is put to bed and tragically found deceased a few hours later. The infant is brought to the mortuary and the specialized autopsy begins. We know ascites is a diagnosis of exclusion, meaning no lethal pathology is found, but what does the pathologist actually observe? Are there any consistent physiological clues?
Often the gross findings are frustratingly minimal. You are examining a perfectly well-nourished child with no obvious disease. However, there is one highly consistent crucial finding that we must clarify at length because historically it caused an appalling medical misapprehension.
Let's dig into that.
In approximately 70% of confirmed SEDs cases, the autopsy reveals the presence of intrathoracic petechia.
Petechia being those tiny, pinpoint, ruptured capillary hemorrhages. Where exactly are they localized?
They are specifically found clustered on the visceral pleura lining the lungs, the epicardium surrounding the heart, and particularly concentrated on the surface of the thymus gland in the superior mediastinum.
Why did the presence of these pinpoint bleeds cause such a catastrophic historical misapprehension?
Because for decades, adult forensic pathologists applied adult trauma frameworks to infant bodies. They observed these petechial hemorrhages on the heart and lungs and immediately assumed they were equivalent to the conjunctival petechia seen in adult cases of mechanical asphyxiation or strangulation.
They assumed it was proof of murder.
They interpreted these intrathoracic spots as definitive evidence of mechanical suffocation. This deeply flawed assumption led to terrible erroneous conclusions that grieving parents had intentionally smothered their infants.
That is horrific. The medical establishment was effectively criminalizing a physiological response to death. What is our modern understanding of these petechiae?
Modern pediatric forensic pathology firmly recognizes that these intrathoracic petechiae in infants are purely agonal phenomena. They are a physiological byproduct of the dying process itself.
Let's break down the pathophysiology of an agonal phenomenon. What is mechanically rupturing those capillaries?
It is a hypoxia-induced mechanism specifically related to the Mueller maneuver.
The Mueller maneuver.
Yes. As the infant's oxygen levels plummet during the terminal dying process, their brainstem triggers intense, involuntary inspiratory gasps. They are desperately trying to pull in air, but often their upper airway is functionally closed or compromised.
Right.
Making violent respiratory efforts against a closed or obstructed airway generates immense negative pressure inside the chest cavity. That severe negative intrathoracic pressure acts like a vacuum, causing the fragile microscopic capillaries on the lungs, heart, and thymus to engorge and rupture.
So it's essentially the body fighting for air.
They're an objective sign of terminal hypoxia and desperate gasping, not a sign of an inflicted mechanical suffocation by a caregiver. Understanding this biomechanical reality is a vital conceptual shift that protects innocent parents from devastating false accusations.
That perfectly illustrates why professional restraint and constantly updating our scientific understanding is so vital. We cannot apply 1970s adult pathology to a modern pediatric autopsy. And because SIDs is purely an exclusionary diagnosis, the investigation leading up to that conclusion cannot rest solely on the autopsy. It demands an incredibly rigorous multi-agency response to rule out environmental or accidental factors.
It demands total integration. You cannot diagnose SIDs on an autopsy table alone. In England, when an infant dies unexpectedly, it triggers immediate statutory involvement from Child Death Overview Panels, or CDOP. The level of meticulous documentation discipline required is intense, guided by standardized national frameworks.
The text explicitly references Form A and Form B4. Let's ground those forms in clinical reality. What data are they actually capturing?
Form A is the rapid initial notification of a child death to the relevant authorities. But Form B4 is the deep investigative dive. It is specifically designed for sudden, unexpected death in infancy. Form B4 mandates a granular, exhaustive review of every conceivable risk factor.
By genetic history.
Yes, it documents the deep family history. Is there a history of unexplained deaths in siblings, which might point to an ultra-rare genetic cardiac channelopathy? It records maternal and paternal smoking habits, illicit substance use, and mental health histories.
And crucially, it requires a heavy focus on reconstructing the microenvironment of the death scene itself.
The scene investigation is as important as the autopsy. Investigators must document exactly what position the child was placed down to sleep, in prone, supine, or lateral. What exact position were they found in?
And where were they sleeping?
Exactly. Was it an improved cot, a car seat, a bouncy chair, or a sofa? Were they sharing a bed with an adult or older siblings? If co-sleeping occurred, the investigation probes deeply. Had the adult consumed alcohol, cannabis, or sedative prescription drugs in the past 8 hours, which would blunt their normal arousal response if they rolled onto the infant?
And environmental factors like temperature.
Was the ambient room temperature excessive? Were there hazardous items in the cot, like heavy duvets or bumper pads?
It's a forensic reconstruction of the exact physical and environmental variables of that infant's last hours. And this response isn't just the police, is it? It's a massive multi-agency effort involving pediatricians, social workers, and specialized health visitors. They conduct a joint home or scene visit within hours of the tragic event.
The overarching goal is to gather every fragment of environmental, clinical, and social data so the pathologist and the multidisciplinary panel can make a truly informed, holistic decision. Is this truly an unexplained SID's death? Was it a tragic accidental overlaying, or are there hidden, sinister factors at play?
Which brings us inevitably to the darkest, most challenging part of this chapter: child abuse. We have to shift our framework from investigating natural vulnerability in tragic accidents to identifying inflicted injury. The term child abuse is a generic umbrella encompassing physical, emotional, sexual abuse, and neglect. But the medical establishment's recognition of physical abuse as a distinct clinical syndrome has a surprisingly short and fraught history. It wasn't always obvious to doctors.
Historically, society and the medical profession largely turned a blind eye. Doctors simply could not fathom or did not want to accuse parents of breaking their own children's bones. Medically, the turning point in consciousness is generally cited as 1946, with a groundbreaking paper published by a pediatric radiologist named John Caffey.
What did he find?
He described a baffling, recurring clinical phenomena: infants presenting with multiple unexplained fractures in their long bones, frequently combined with chronic subdural hematomas in the brain.
Seeing bones breaking and brains bleeding simultaneously without a clear history of a massive trauma, like a high-speed motor vehicle collision.
Exactly. Now, earlier in the 1860s, a French forensic physician named Auguste Ambroise Tardieu had meticulously described similar findings of abuse and neglect. But his work didn't shift the global medical paradigm. Caffey's radiological evidence brought it into modern medical consciousness.
And then Kempe's work in the 60s.
Yes, in 1962, pediatrician C. Henry Kemp and his colleagues published a landmark paper titled The Battered Child Syndrome. That publication revolutionized pediatric, psychiatric, and forensic medicine. It forced the medical community to abandon its denial and formally recognize that parents and trusted caregivers were systematically inflicting these horrific mechanisms of injury.
It sparked the creation of modern safeguarding protocols and child protection agencies. But legally, even when doctors identified abuse, there were massive loopholes that allowed abusers to walk free, particularly the issue of mutual silence in a shared household.
That was a catastrophic, enduring legal failing. If an infant was beaten to death and both parents or cohabiting adults simply refused to speak, blaming each other or maintaining total silence, prosecutors were frequently paralyzed.
Because they couldn't prove who dealt the fatal blow.
They couldn't prove which adult delivered the fatal blow beyond a reasonable doubt, so they often couldn't convict either of them of murder or manslaughter. The UK finally addressed this glaring loophole with the Domestic Violence, Crime and Victims Act, 2004.
How did that specific act change the legal landscape for prosecutors?
It introduced the novel statutory offense of familial homicide, or causing or allowing the death of a child or vulnerable adult. This offense carries a severe prison sentence of up to 14 years.
So it shifted the responsibility.
The act placed a clear, unavoidable legal responsibility on adults who have frequent contact with a child. If you knew, or reasonably should have known, that the child was at significant risk of serious physical harm from someone in that household, and you failed to take reasonable steps to protect them, you can be prosecuted. You can no longer hide behind a wall of silence while a child is killed in your home.
The law evolved to capture the perpetrators, but the forensic pathology still bears the burden of proving the abuse occurred in the first place. When a child tragically dies and non-accidental trauma is suspected, the autopsy is entirely different from a standard adult post-mortem.
It is a vastly more complex, highly specialized procedure. In many jurisdictions, it is mandatory that these autopsies are carried out by dedicated pediatric forensic pathologists in regional specialist centers. They have to account for the unique developmental differences, the incomplete bone fusion, and the specific biomechanics of infant trauma we discussed earlier.
And the text makes it explicitly clear that a pediatric forensic autopsy doesn't even begin in the mortuary with a scalpel. It begins in the radiology suite.
Always. A full, comprehensive radiological skeletal survey must precede any physical examination or dissection of the body. The radiologist is looking for evidence of occult, old, healing fractures. Perhaps a healing rib fracture with callus formation existing right alongside acute recent fractures.
It builds a timeline.
This radiological survey provides a vital objective timeline of chronic abuse, proving this was not a single, tragic, isolated accident.
Here's where it gets really interesting. Let's dive deep into the typology of trauma. We need to build a framework for distinguishing normal childhood injuries from inflicted abuse. Let's start with the surface. Bruising. Toddlers are clumsy, they fall constantly. How does a clinician or pathologist differentiate between a normal, active child taking a tumble and an infant being subjected to physical abuse?
You apply a rigorous framework based on 3 pillars: site, age, and pattern. Accidental bruising in children is incredibly common, but it follows highly predictable biomechanical patterns based on their specific developmental stage.
Right, because of how they move.
Toddlers who are learning to walk and run fall forward. They predictably bruise the bony prominences, their shins, their knees, their elbows, and their foreheads. That is normal, expected childhood trauma.
But what are the specific clinical red flags that shift the differential diagnosis to abuse?
The absolute most critical red flag, your primary clinical anchor, is bruising in a non-mobile infant. There's a saying in pediatrics: those who don't cruise rarely bruise.
That's a great mnemonic.
It's very true. If a baby is developmentally unable to crawl, roll, or pull to stand, they physically cannot generate the kinetic energy or velocity required to injure themselves accidentally. Any bruising over soft tissues in a non-mobile infant must be viewed as highly, highly suspicious of non-accidental injury.
What about the anatomical site of the bruises? Where shouldn't a child bruise accidentally?
Bruises on the face, the pin of the ears, the inner lips, the fleshy neck, the lateral thorax, the soft abdomen, and the buttocks. These anatomical areas are naturally protected during normal, forward-falling childhood accidents.
So if you see a bruise there.
If you examine an infant and see a bruise on the complex cartilage of the ear or deep bruising on the soft tissue of the abdomen, you must immediately suspect inflicted trauma.
And the pattern or shape of the bruise itself can serve as a literal imprint of the weapon or the hand, right?
Yes, imprint marks are vital forensic evidence. Bruising distributed around the upper arms, the wrists, the ankles, or the rib cage may show a distinct localized pattern of oval fingertip grips. That is clear evidence that an adult forcibly grabbed, squeezed, and held the child.
Or marks from objects.
If you observe multiple bruises of uniform shape, such as parallel linear bruises from a rod or stick, or bruises that carry the distinct, measurable imprint of an implement like a belt buckle or a shoe, that strongly suggests physical abuse. The forensic physician must meticulously document the caregiver's explanation for every single bruise and cross-reference it against the physical, biomechanical reality of the injury.
If the stories don't match the science?
If the caregiver says the infant rolled off the bed, but the child has fingertip bruises on their uppy arms, the history fundamentally contradicts the pathology.
If the surface bruising raises suspicion, the investigation must move deeper to the skeletal structure. We mentioned the importance of the skeletal survey earlier. What are the specific radiological guidelines when abuse is suspected?
The Royal College of Radiologists in the UK provides highly specific mandatory guidelines. If physical abuse is suspected in a clinical setting, the imaging protocol must always include a full, high-detail skeletal survey for any child under 2 years of age.
And for even younger children?
If the child is under 1 year of age, the protocol mandates both a complete skeletal survey and a CT scan of the head to rule out occult intracranial trauma.
Let's focus on the thorax. The text emphasizes that rib fractures in infants are exceptionally rare in normal accidental trauma. What is the biomechanics behind an abusive rib fracture? This is a critical differentiation point for anyone listening who might be reviewing pediatric x-rays.
It's a matter of physics colliding with infant anatomy. An infant's ribs are highly cartilaginous and extremely pliable. They are designed to compress significantly during the birth process. They bend easily, absorbing force. Therefore, it takes substantial, highly specific, and focused force to snap them.
So what pattern do we see in abuse?
In abuse cases, the classic radiological pattern is posterior rib fractures. On a radiograph, or during a post-mortem, you might observe areas of healing bone nodular callus formation, lying in a vertical line directly adjacent to the vertebrae at the costovertebral articulation. It visually looks like a string of beads running down the back of the rib cage.
What specific mechanism of injury causes that string of beads fracture pattern at the posterior aspect of the ribs?
It is highly indicative of forceful, violent anterior-posterior squeezing of the chest. The perpetrator places their adult hands completely around the infant's small chest, pressing their thumbs hard onto the anterior sternum, while their fingers dig deeply into the back on either side of the spine, and they squeeze violently.
That's a devastating image.
The ribs are compressed front to back beyond their elastic limit. They bend over the transverse processes of the vertebrae, which act as a hard fulcrum, and the ribs snap posteriorly near the spine.
Now, a very common defense in these cases is the CPR defense. Parents or caregivers will claim, "We found the baby unresponsive, we panicked, and we performed chest compressions. We must have broken their ribs trying to save them." Is that a valid explanation for posterior rib fractures?
This is where forensic biomechanics becomes the arbiter of truth. CPR can absolutely cause rib fractures in infants, but the resulting fracture pattern is completely different. Proper or even frantic CPR involves pushing straight down on the anterior sternum.
Vertical compression.
This vertical compression causes the ribs to bow outward laterally, resulting in anterolateral fractures breaks located on the front or the sides of the rib cage. It is highly unlikely, biomechanically almost impossible, for standard anterior chest compressions to cause posterior rib fractures near the spine.
So the CPR defense falls apart.
Therefore, if you identify posterior rib fractures in an infant who received CPR, that CPR attempt does not explain the injury. The posterior fractures demand a full, aggressive child protection investigation for abusive squeezing.
That biomechanical differentiation is exactly the kind of nuance we need to anchor. What about skull fractures? Toddlers fall off beds, changing tables and sofas constantly. How do we differentiate an accidental low-velocity fall from an inflicted, high-energy skull fracture?
The text provides some very concrete, reassuring data here regarding common accidents. A simple fall from a relatively low height can cause a skull fracture. Biomechanical studies and clinical reviews show that a headfirst fall from just 0.9 meters, which is roughly the height of a kitchen counter or a changing table onto a hard concrete or tile surface, has a high likelihood of causing a fracture.
Even onto carpet.
Even falling onto a carpeted floor from that height carries a statistically significant risk. So if a parent reports that a child fell off a counter and the X-ray shows a simple, narrow linear skull fracture on the parietal bone, that pathology might be entirely consistent with the reported accidental history.
So what specific characteristics make a skull fracture highly suspicious for non-accidental abuse?
We look for markers of complexity and massive energy transfer. Abusive skull fractures require forces far exceeding a simple tumble. They are far more likely to be multiple intersecting fractures rather than a single linear crack.
They shatter.
They are frequently comminuted, meaning the skull bone is shattered into multiple fragments. They are more likely to be bilateral, occurring on both sides of the head simultaneously from a crushing force, or they cross the major suture lines of the skull plates, which requires immense directed kinetic energy to achieve.
The topic of massive energy transfer to the head perfectly transitions us into one of the most intensely debated areas of pediatric forensic medicine. Head injuries are the most frequent cause of death in fatal child abuse. And we have to tackle the highly controversial terminology and evolving science around what was historically called shaken baby syndrome.
Shaken baby syndrome, or SBS, has been the epicenter of massive medical, pathological, biomechanical, and legal debate for the past 2 decades. The classical historical diagnosis of SBS depended almost entirely on the radiologist or pathologist identifying a specific triad of injuries.
Which were?
Subdural hemorrhage, which is bleeding beneath the dura mater of the brain. Retinal hemorrhage, which is multi-layered bleeding in the back of the eyes. And encephalopathy, which manifests as severe brain swelling, hypoxic damage, and altered neurological status.
The prevailing hypothesis for decades was that violent, repetitive shaking back and forth caused the relatively small infant brain to shear inside the larger cranial vault. This rotational shearing force tore the fragile bridging veins, causing the subdural bleed, and tore vessels in the eye, causing the retinal bleed, resulting in the triad. Why has this widely accepted mechanism become so fiercely contested in modern courts?
It is contested because our scientific understanding of pathology has evolved, and the legal implications of getting it wrong are catastrophic. Let me be clear. There is absolutely no doubt in the pediatric or forensic community that infants suffer horrific abusive head injuries, and that violent impact, with or without shaking, causes devastating, lethal physical effects.
But the triad itself is under scrutiny.
But the scientific consensus has shifted regarding the exclusivity of the triad. The finding of the triad alone, just the subdural bleed, retinal bleed, and brain swelling, should not lead to an automatic, unquestioned assumption of non-accidental injury.
Why not? If the triad is present, can other non-abusive pathologies cause those exact same three signs?
Yes, we now understand that certain complex natural diseases, severe bleeding disorders, profound hypoxic ischemic events, sinus venous thrombosis, or even severe high-energy accidental impacts could potentially mimic some or all of the findings of the triad.
That's a huge shift.
The triad is a description of profound head pathology. It is not by itself a definitive diagnosis of a specific criminal mechanism. Therefore, diagnosing abuse requires immense holistic clinical context. You cannot look at the triad in a vacuum. You must integrate the full skeletal survey looking for occult fractures, the detailed clinical history, the precise timeline of neurological collapse, and the scene investigation.
And because of this scientific nuance and legal controversy, the very language the medical community uses has fundamentally changed, hasn't it?
It has, and it's a necessary evolution. The medical community has largely moved away from the mechanistic term shaken baby syndrome. We now utilize terms like abusive head trauma, AHD, or inflicted head injury, IHI.
Why are AHT or IHI superior terms from a forensic perspective?
Because they focus precisely on the objective clinical, pathological, and radiological findings, the actual documented trauma to the head and brain, rather than assuming or asserting a specific, unwitnessed kinetic mechanism like shaking. It is more scientifically accurate because it acknowledges that impact is often a major component, and it is legally neutral. It describes what we see, not what we assume happened in an empty room.
Let's dig deeper into the specific ocular pathology associated with abusive head trauma, because the eyes can tell a profound, highly specific story about the extreme forces the child experienced. Every suspected abuse case requires an urgent examination by a specialist pediatric ophthalmologist. What exactly are they looking for beyond general bleeding?
Retinal hemorrhages are the classic finding, often too numerous to count and extending to the periphery of the retina. But the text details even more specific, highly predictive markers of abuse. Recent ophthalmological studies highlight the presence of cherry hemorrhages. These are isolated, elevated, perfectly circular bleeds typically found in the equatorial region of the retina.
And what specific physical force mechanism causes a cherry hemorrhage?
Biomechanical modeling associates them with extreme rotational and acceleration-deceleration forces. You also see the formation of perimacular ridges, which are elevated, circular folds in the retina caused by the violent tearing of the internal limiting membrane.
The text mentions vitreomacular traction as the underlying cause for these folds and cherry hemorrhages. Let's explain that anatomy clearly.
Think of the anatomy of the eye. The vitreous body, the dense, clear jelly filling the main cavity of the eye, is firmly attached to the delicate retina at the back. When an infant's head is subjected to massive, violent rotational forces, whiplashing aggressively back and forth, the heavy jelly inside the eye physically lags behind the rapid movement of the surrounding skull and sclera.
So it pulls.
This creates massive shear forces. The heavy jelly pulls violently against its attachments to the retina. That traction, that intense pulling force, is what physically tears the delicate membranes, creating these highly specific folds, ridges, and hemorrhages. Infants under 16 months of age are particularly anatomically susceptible to this specific type of traction damage due to the firm adherence of their vitreous.
That is a devastating biomechanical mechanism to visualize, the rotational force literally tearing the inside of the eye apart. Let's move from the head to other critical areas of trauma. The soft tissues, oral cavity, and internal organs also hold critical forensic evidence. Let's start with the mouth. What is a torn frenulum, and why is it such a significant finding for an examining pediatrician?
The frenulum, or frenum, is that small, tight web of mucosal tissue connecting the inside of your upper or lower lip to your gum line. A torn frenulum in a non-mobile infant is a highly recognized clinical red flag for abuse.
I've heard of residents immediately assuming abuse when they see a torn frenulum. How does it physically get torn in an inflicted manner?
It can be torn by a tangential shearing blow across the mouth, such as a heady slap to the face. But classically, in infant abuse scenarios, it is caused by the perpetrator forcibly, violently ramming a feeding bottle, a pacifier, or a spoon into a crying baby's mouth, aggressively tearing the tissue between the lip and the gum.
But we have to be careful here. Is a torn frenulum definitive, standalone proof of physical abuse?
No, and the text is very careful to state this caveat. While current pediatric evidence indicates that a child presenting with a torn frenulum absolutely must undergo a full urgent child protection evaluation, it is not an automatic conviction.
Context is key again.
If the skeletal survey is completely clear, there are no retinal hemorrhages, no other suspicious bruising, And the social work assessment identifies no risk factors. The torn frenulum alone is not diagnostic of physical abuse. It could theoretically happen from an accidental impact with a toy. It is a sentinel indicator that demands thorough investigation, not a definitive conclusion in isolation.
Let's move deeper into the body. Visceral injuries, injuries to the internal organs, are the second most frequent cause of death in fatal physical child abuse, right behind head trauma. How does an infant-specific abdominal anatomy make them so uniquely vulnerable to blunt force?
An infant's anterior abdominal wall is incredibly thin and pliable. It lacks the thick protective musculature and the subcutaneous fat pads of an adult. It offers almost zero structural protection to the delicate organs lying immediately beneath it.
So a heavy blow from the front, a punch, a kick, or violent kneeling has devastating, unimpeded consequences.
Precisely. The mechanism of injury here is a massive crushing force. A heavy, directed blow to the front of the abdomen compresses the internal organs, specifically the duodenum, the jejunum, and the highly vascular mesentery, forcing them violently backwards, crushing them directly against the hard, unyielding prominence of the lumbar spine.
What kind of specific internal injury does that crushing force against the spine cause?
It causes brutal, often fatal trauma. You see transection, which is the literal tearing or complete perforation of the bowel wall. This immediately spills highly infectious intestinal contents and digestive enzymes into the sterile abdominal cavity, leading to rapid fulminant peritonitis, overwhelming septic shock, and death if not immediately surgically repaired. The crushing force can also severely lacerate or avulse the mesentery, leading to massive, rapid internal hemorrhage.
What about the larger solid organs like the liver or the spleen? Are they equally vulnerable?
The liver in a young child is relatively large compared to their body size, and its lower edge actually protrudes significantly below the protective cage of the lower ribs. It is highly vulnerable and can be easily lacerated or ruptured by direct blunt force trauma to the upper right abdomen, causing massive, fatal bleeding into the peritoneal cavity.
And the spleen.
The spleen, however, sits tucked much higher up and further back in the left upper quadrant, relatively well protected by the rib cage. Consequently, isolated splenic injuries are actually quite rare in physical child abuse because of its anatomical protection.
Beyond blunt trauma, the text details the forensic evaluation of burns and bites. These are visceral indicators of profound cruelty or extreme criminal neglect. Let's discuss pattern recognition in burns because the shape tells the story of the mechanism.
Burns can be tragic household accidents, or they can be intentionally inflicted. The forensic physician looks intensely at the pattern, the depth, and the distribution. Forced immersion in scalding hot water, these highly distinct glove and stocking scald patterns on the hands or feet, with extremely sharp, unsplashed lines of demarcation.
Showing they were held down.
This indicates the child was forcibly held immobile in the burning water rather than accidentally pulling a cup of tea over themselves, which leaves an irregular splashing, downward-flowing pattern.
The text specifically highlights the forensic pathology of cigarette burns. What does a deliberate cigarette burn look like compared to, say, an accidental brush against a hot iron or oven door?
A deliberate cigarette burn involves firm, sustained, intentional contact of the burning ember with the infant's skin. It presents clinically as a deep, partial thickness or full thickness burn. It is usually perfectly circular or slightly oval, measuring precisely 5 to 10 millimeters in diameter, matching the caliber of a cigarette.
And as it heals?
Visually, as it heals, it often develops a distinct, punched-out appearance with a depigmented, lighter, scarred center, surrounded by a hyperpigmented, darker rim. You have to be careful to differentiate these from old, healed vaccination scars or the crusting phase of skin conditions like impetigo, but the precise, uniform, circular pattern, especially if multiple are present, is highly suspicious of inflicted torture.
And human bites. Sadly, these are a disturbingly common finding in abuse cases. What is the immediate, non-negotiable clinical priority if an emergency physician suspects an infant has been bitten?
The absolute immediate priority before cleaning the wound or doing anything else is obtaining a double swab for DNA. You swab the center and the periphery of the bite mark to recover the saliva and therefore the cellular DNA of the perpetrator.
That makes sense for identification. But what about forensic odontologists examining the bite mark itself and matching it to a suspect's dental mold? We see that presented as absolute proof on television crime dramas constantly.
You see it on television, but in the reality of modern forensic science, it is viewed as highly controversial, subjective, and increasingly discredited. A forensic odontologist can certainly examine the injury and confirm it is a human bite based on the arch shape, and perhaps distinguish an adult bite from a toddler sibling's bite based on the intercanine distance measurement.
But matching it to one specific person.
Conclusive, definitive pattern matching. An expert testifying in court that these specific teeth definitively made this exact mark on the skin to the exclusion of all others has suffered severe, scientifically validated criticism.
Because skin isn't a firm substrate like wax or dental putty.
Exactly. Skin is highly elastic. It distorts during the bite, it swells immediately after, and it changes shape depending on the posture of the victim. In the United States, erroneous bite mark matches presented by overly confident experts have led to several high-profile, catastrophic, wrongful convictions. DNA recovered from the saliva is the objective gold standard. Visual pattern matching of teeth to skin is viewed with extreme caution by modern courts.
We have to address Section 9, which covers child sexual abuse. This is a grim, devastating reality, and the text notes a deeply unsettling statistic. Up to 1 in 20 children in the UK may experience some form of sexual abuse. We cannot just brush past a statistic like that. The medico-legal boundaries and the forensic examination protocols here are highly specialized.
It is a pervasive, systemic issue, and the medico-legal definitions, as outlined in Box 7.2 of the text, are vital for clear documentation, multi-agency investigation, and successful prosecution. The law and the medical examination distinctly separate contact abuse from non-contact abuse.
Contact abuse is the physical, tactile act.
Yes, sexual touching, digital or penile penetration of the vagina or anus, or forcing a child to take part in physical sexual activity. The forensic medical examination for suspected contact abuse is incredibly specialized. It requires highly trained pediatricians using specialized equipment like colposcopes, which are essentially lighted binocular microscopes to document microscopic trauma.
They use specific dyes, too, don't they?
They may use specialized dyes, like toluidine blue, which highlights micro-lacerations in the delicate mucosa that are invisible to the naked eye.
And the physician has to differentiate inflicted sexual trauma from accidental straddle injuries. A child slipping and falling hard onto the crossbar of a bicycle.
That differentiation is crucial. Accidental straddle injuries almost universally affect the anterior or front structures of the labia majora, the clitoris, or the anterior fourchette because they strike the hard object falling forward. Conversely, penetrative sexual abuse typically causes trauma to the posterior structures, the posterior fourchette, deep hymenal transections extending to the base, or deep anal fissures and loss of sphincter tone. Documenting that specific anatomical location is vital evidence.
What about non-contact abuse? It doesn't leave a physical scar for a colposcope to find, but it is equally damaging and prosecutable.
Non-contact abuse involves different mechanisms of profound harm. Systematic grooming, exposing a young child to adult pornography, forced voyeurism, or the making, viewing, and distributing of child abuse images. The management and investigation of these cases rely heavily on digital forensics, seizing and analyzing devices, and specialized trauma-informed forensic interviewing techniques.
It's a huge multidisciplinary effort.
It requires a coordinated approach involving pediatricians to rule out physical trauma, specialized child abuse police investigators, and social workers. The psychological impact is devastating, and securing a disclosure from a terrified, manipulated, or pre-verbal toddler is one of the most complex challenges in the entire criminal justice system.
We have covered a massive, heavy amount of ground today. From the rigid legal definitions of stillbirth and maceration through the biomechanics of skeletal trauma to the darkest corners of inflicted physical and sexual abuse. To wrap this up, if we connect this to the bigger picture of where forensic medicine is heading, what is the future? How might the burden of proof shift in the next decade for these incredibly complex cases?
If we look at the horizon of pediatric forensics, I believe the biggest paradigm shifts will come from molecular and digital technologies. Consider the molecular autopsy. Right now, SIDs is a diagnosis of exclusion based on gross and microscopic pathology. But with rapid advancements in next-generation sequencing, we are increasingly able to perform post-mortem genetic testing.
Looking for hidden answers.
Exactly. We may soon find that a significant percentage of these unexplained SIDs deaths are actually caused by ultra-rare, inherited genetic cardiac channelopathies, like long QT syndrome, that leave zero physical trace on the heart muscle but cause lethal arrhythmias.
That would completely change the landscape. It provides families with a definitive medical answer instead of a terrifying question mark, and it shifts the burden away from suspicion. What about imaging?
I think we will see the integration of artificial intelligence in forensic radiology. An AI model trained on tens of thousands of confirmed pediatric abuse radiographs might be able to spot microscopic, healing metaphyseal corner fractures or hairline rib fractures that a tired human radiologist might miss at 2 a.m.
That's a fascinating prospect.
AI won't replace the pathologist, but it will refine the objective data, making it harder for abuse to be missed and equally making it harder for natural diseases that mimic abuse, like osteogenesis imperfecta or severe rickets, to be misdiagnosed as trauma. The future is about increasing our objective precision so we can achieve absolute truth.
The ultimate goal: protecting the vulnerable while safeguarding the innocent through irrefutable science. Now, to anchor this extensive knowledge for those of you actively preparing for exams or needing a sharp clinical refresher, here are your rapid, single best answer recall prompts. I will read the prompt, we will pause briefly, and then I will give the answer and tell you which core concept to review if you missed it. Test your reasoning. Prompt 1. Under the modern Stillbirth Definition Act 1992, at what exact gestational age is a fetus legally classified as a stillbirth if it is delivered, showing absolutely no signs of life? Answer: 24 weeks completed gestation. If you missed this, review the stillbirth definitions and viability section of Chapter 7. Prompt 2. You are reviewing a post-mortem skeletal survey of an infant and observe a string of beads appearance of nodular callus formation on the posterior aspect of multiple ribs. What specific biomechanical mechanism of injury is this highly indicative of? Answer: forceful anterior-posterior compression, specifically violent squeezing of the chest, utilizing the spine as a fulcrum. It is not caused by standard CPR. If you missed this, review the biomechanics of skeletal injury section. Prompt 3. True or false? The finding of numerous intrathoracic petechia scattered on the surface of the thymus gland in a suspected SID's case is highly indicative of inflicted mechanical suffocation by a caregiver. Answer: false. These are agonal phenomena. They are caused by severe negative intrathoracic pressure generated during terminal hypoxic gasping, not by inflicted suffocation. If you miss this crucial distinction, review the unexplained death in infancy and pathology section. Prompt 4. When examining an infant post-mortem, how does the pathological process of maceration fundamentally differ from standard putrefaction? Answer: maceration is an aseptic, autolytic decomposition process occurring in utero due to prolonged exposure to warm amniotic fluid prior to birth. Putrefaction requires birth, breathing, and subsequent exposure to environmental air and gas-producing bacteria. If you missed this, review the postmortem changes in fetuses section. Prompt 5. An ophthalmological examination of an infant with suspected abusive head trauma reveals the presence of cherry hemorrhages and perimacular ridges. What specific physical force mechanism causes the vitreous to tear the retina in this manner? Answer: vitreomacular traction resulting from extreme rotational or violent acceleration-deceleration forces causing the dense vitreous jelly to shear against the delicate retinal membranes. If you missed this, review the ocular injuries and biomechanics section. Prompt 6. According to the specific parameters of the Infanticide Act 1938, a mother convicted of causing the death of her own child under 12 months of age due to a disturbed balance of mind caused specifically by giving birth or lactation is legally guilty of what specific offense? Answer: infanticide, which is punished as manslaughter, removing the mandatory life sentence associated with murder. If you missed this legal nuance, review the infanticide and the law section. Thank you for joining us for this intensive deep dive into the forensic investigation of deaths and injury in infancy. We strongly encourage you once more to read the entirety of Chapter 7 of Simpson's Forensic Medicine, as it contains invaluable clinical photographs, detailed histological nuance, and extensive legal context that we could not fully replicate here. We wish you the absolute best in your board studies, your clinical exams, and in your future medical practice. Take care.